Thank you, Dr. Madhura, for the excellent presentation. Now we will move on to our question and answer session. So now I will request Dr. Ramakrishna to take up the questions received from the audience for our speakers and enlighten us.
Thank you, Ramon, and thank you, Madhura. I think those are very exhaustively reviewed. We have some questions which will again, I think you've answered them, but always iteration or reiteration definitely helps and in the discussion. So the first question is from Dr. Debashish Roy. And Madhura, if you can take this, please. The question is, patients don't get results in 1 or 2 weeks. How long does it take to get complete relief? You have addressed it, but you want to say it again.
So first 2 weeks, I hope you agree with me, sir. So
Yeah,
I'm
yes.
not. So would you like to answer the question, sir?
No, you should. Yeah.
So within 2 weeks, it's very difficult to get a response. So at least 4 weeks to 8 weeks. But I think Dr. Mohan Prasad wants to answer that.
Yeah, I would agree. It's slow to act. So within 2 weeks, you may not get a complete response. There'll be a partial response.
So both the next question is actually to you from Dr. Mishra. How can a physician differentiate PDS and EPS clinically?
Sir, that is very easy, sir. As I explained to you, Room 4 beautifully describes. So epigastric pain and burning will become EPS. Somebody comes to you with upper abdominal pain and burning sensation, so related to meals. So this is EPS. Whereas on the other hand, somebody has more early satiety, that's with small quantity of meal, he feels full. And then he feels bloated or distended. That becomes postprandial distress syndrome, PDS.
Yes. So in fact, to Dr. Mishra, just a little commentary. If you do a CT in a person who's fasting, you'll find that the stomach is actually tubular. It is not like the bag that we actually show in our pictures. And then when they drink liquid, the second half of the distal half of the tube doesn't do anything. The proximal half, which is the fundus, dilates it like a balloon and it accommodates. Now, in people with PDS, what happens is this ballooning of the proximal stomach doesn't happen. So the fluid goes through into the second part, which is closed or tight. And that is what causes discomfort. So, and that is where I think these medicines are useful. And as Dr. Mohan Prasad said, there's a lot of overlap. So there is pure PDS, there's pure EPS, and then there's all kinds of overlap. And also with lower bowel symptoms, you'll have an overlap. Again to you, Mohan, this is from Dr. Manish Pahukar. What is the diagnostic investigation for fundus accommodation?
Wow, a great question. A simple diagnostic test will be to make a patient drink water. If he or she can drink at least 500 ml of water, that means the fundic accommodation is okay. Anything below that, usually these people with FD, with poor accommodation, cannot drink beyond 300 cc of water. That's what we find. So because water loading test is very important, integral of electrogastrography. So you don't need to spend money at all. Give couple of glasses, 2 glasses of water, each glass is 250 ml. So make him or her drink 500 ml. And he or she can drink more. Some people can even consume up to 750 ml, 1 liter and all they can take. That means accommodation is good. Somebody who is unable to drink beyond 250 to 300 ml definitely has got a poor fundic accommodation. One of the cheapest ways to test. And then, of course, as B.S. Ramakrishna sir said, you can do imaging. So pre and post.
No, I didn't say that. No, that's a very nice tip to all of you in the audience. A very clinical way of judging whether somebody has a pure PDS. So there's a question to you, I think, Dr. Madhura, from Dr. Swapnil Shakla. Which type of patient can we use acotamide empirically?
So acoshamide we can probably use in these patients who have an immediate, like they take a small meal and that's it, they are done for. They cannot even take another bite. Obviously, when we are ruling out all the red flag signs, no gastric malignancy, and we are checking for H. pylori, treating gastritis, treating with PPIs, and then only we are going to go in, not immediately into acoshamide. So, but those are the type of patients who will benefit with acoshamide. So what would you say, sir?
Yeah, I agree. Bon, any comments?
Sir, no, sir.
All right. So the next question is from Dr. Ashish Verma. How long should first-line treatment, that is pre-PI, prokinetics, acotamide, and neuromodulator may not be first-line, be tailored for FD patients based on the symptom presentation? So how long should they be tailored?
Yeah,
For
what I would do,
patients?
I would recall the patient every 4 weeks. So sometimes if they don't have a relief, I'll tell them, report to us. Whenever you don't get a relief even within 2 weeks, please report to us. We'll try to some add on or just modify the treatment schedule. But as far as the proton pump inhibitors are concerned, we would like to deprescribe over a period of time. So I mean, we always get, there is something called a Leeds dyspepsia score. You can easily do that. And if you want to do a QGRD, a GRDQ score can also be done. So these two scores can tell us how the patient's symptoms have improved. So this is simple. You can get it just with a Google. You can get it. So at the baseline, do the QGRD score and the Leeds dyspepsia score. They're simple scores, believe me. You can objectively give points and then call them back every 4 weeks just to see how the improvement is. I would like to start tapering the PPIs once the epigastric burn or pain gets controlled, the reflux gets controlled. So I believe in deprescribing PPIs because long-term PPIs probably can be associated with some side effects. So we try to reduce the drug. But the prokinetics, like for example, acoshamide, safety has been proven even up to 1 year of therapy. People have continued up to, publications are there up to 1 year. It's very safe. So, so you can continue depending based on the symptomatology. You can continue because you would agree with me. You can't spot anything organic here. These are all functional. So you just keep counseling them and encouraging them that you'll become all right. And once they start improving, you start tapering the drugs. You can always step up if there is a recurrence or increase in symptoms.
Yeah, absolutely. The next question from Dr. Sanjay Sanghi. How long does acoshamide need to be prescribed to a patient with functional dyspepsia?
Madhura?
Yes, so acoshamide should at least be prescribed for 2 weeks, and it's all based on symptoms, as Dr. Mohan Prasad is telling. And it's like you talk more. Actually, for PDS patients, we talk more than prescribe more. So that is what matters. So hand holding them, and I think you can try to taper as much as possible. Whatever, so we know that it is safe, but once they start responding after like 4 weeks or so, you can start coming down and you can take it off and see how they do. In all these studies, after 4 weeks, they cut it off for 4 more weeks, and they all did well. So
Madhura is a charmer, so she'll charm everybody, and she got a lot of fans. Those patients want to see only Madhura.
But you also presented data to show it you can safely continue it for up to a year.
yes,
So-
we can
so-
safely continue it for a year. Yes.
And I think in many cases, like I'm sure all of us are practical or pragmatic, we tell them, if you need to take it again, they take it again. I'm sure you all do that.
Absolutely, sir.
Okay, so there is a question from Dr. Jayanta. When should a physician refer an FD patient to a gastroenterologist? And Mohan, you have to take this. When should these patients be referred to a gastroenterologist?
So a patient with dyspepsia definitely needs to be referred to a gastroenterologist, because first burden on us or the onus is to rule out an organic cause of dyspepsia. Because see, if in case there are alarm symptoms, or if the physician tries some drugs for a short while, like 2 weeks, 4 weeks, there is no relief, definitely the patient has to be referred to a specialist. So maybe 2 to 4 weeks the physician can try, and if it doesn't work, then we need to find out what exactly is happening in this patient. Is it organic? Is it functional? If it is functional, is it on FGID? Is it GERD? Is it EPS? It is PDS or IBS or overlap? Then accordingly, we need to tailor the drugs. So I think, my submission to BSR sir is, I think physicians might not have time to concentrate on the the gastroesophageal disorders, FGIDs. They concentrate more on diabetes and dyslipidemias, cardiac problems, neuro problems. So I think a physician can try for 2 to 4 weeks, using the common sense and some simple tests like ultrasound and endoscopy. If beyond that, if the patients do not find a relief, patient has to be referred to a super specialist for a proper evaluation. Then I think it could be rewarding.
Can I just add one thing, sir? Like,
Yeah.
it's also very important to segregate a group of patients, a subgroup, which is gastroparesis, because it's all completely mixed up in the same FD and PDS symptoms. To segregate those gastroparesis, give them targeted therapy will be very, very important and help those.
Absolutely. So, a question again to you, Mohan, from Dr. Santosh Kumar. How do you differentiate between PDS and epigastric pain syndrome? And in a patient under 50 without red flags, when do you choose empiric treatment versus upper GI endoscopy? I know you've talked about it, but maybe reinforcing.
Yes, I think if, say, for example, in Kashmir Valley, they say even 45 years is a trigger. If somebody comes for the first time with dyspepsia, even at 45 years, they diagnose cancers, the gastric cancer. But that is a pocket where the GI gastric cancers are more for environmental reasons, several reasons, including the hookah, smoking, and so many things happening there. So it doesn't apply to the rest of the country, but generally, overall, I think even BSR sir, I want your comment on that. Do we take 50 years as a cutoff, or do we take 45 years for a country like India? And somebody with unexplained dyspepsia and progressive weight loss or any other overadded, superadded symptoms, alarm symptoms, then I think we should immediately investigate.
Certainly, with alarm symptoms, we should definitely investigate. The question of age is very much, I think, is an ad hoc decision sometimes. So, yes, traditionally I would have taken 50, but there are people who come to you and you talk to them, you ask them, why have you come to me? And they might tell you, I want an endoscopy because I want to know what's happening inside. And that happens very often, you know that. And because there's somebody in the family who's had a cancer. If there is a family history of gastric cancer, you did mention this. If there's a family history of gastric cancer, definitely a threshold would be lowered.
And in a patient who wants an endoscopy, we better do it. Because once we do an endoscopy and say, hey, you have nothing, then that will completely solve this functional dyspepsia. That anxiety stress factor will go. So they might be, feeling fit and fine. So it's a psyche that works. So sometimes we use it, to tell them, okay, look here, there's nothing. So no problem.
So Dr. Guruswamy asks, can acotamide be prescribed for gastroparesis? So, since you brought up gastroparesis,
I think so.
Madhura,
I
you
think
should.
I put myself in this situation. Because when in gastroparesis again, where they have more of vomiting rather than all the other symptoms. So most of these gastroparesis patients will have bloating, will have early satiety, everything, but their vomiting is a little more disproportionate compared to the other symptoms. And seeing that some food stasis, or having a proper even after entire overnight fast, you see still food in the stomach, it's absolutely indicative that it is gastroparesis. And again, doing a scintigraphy and emptying study will help. But whether acosamide will help, of course, acosamide is going to improve the gastric accommodation, but gastroparesis will have a base in emptying, and also it could be the interstitial cells of Cajal, or it could be anthropyloric, incoordination in emptying. So I don't know, acosamide is not related to these two directly, only the fundic accommodation and gastric motility also is improved. So I have to ask Dr. Ramakrishnan.
I agree with you. So I think I would use it more when there is early satiety and fundic accommodation is involved. It is a weak prokinetic agent as far as the gastric peristalsis is concerned. It's not a very strong drug. So in clinical practice, for a typical gastroparesis, acosamide will not be the probable answer. We need to use some other prokinetics like etopride, which might work, or levosulpiride, good drug, but the problem is with the family history of Parkinson's or elderly, I would be very, very scared. And also people lactating, females can have galactoria because of, the prolactin and all those problems. I had a male who developed gynecomastia, painful gynecomastia following levosulpiride. So these sort of problems can happen because of hyperprolactinemia. So I'm a little worried about the drug, but nevertheless, people with so much of stress, anxiety, and all that, probably it's a good prokinetic agent for a short term. I wouldn't use it in long term.
Would there be any situation where you might use acosamide with another prokinetic?
Yes, of course. Definitely, I would. So if there is a fundic accommodation defect and with a gastroparesis, I will probably use a combo drug like etopride with acosamide. It can be used in clinical scenario, in real life scenario, we use it.
Right. So another question from Dr. Faisal, which is, when would you consider using acosamide or treatments like PPI or H. pylori eradication in PDS? How do you prioritize which you use first?
Sir, first, if there is H. pylori, I would eradicate H. pylori.
So
because people are very...
H. pylori first.
Yes, absolutely. Because people have shown in all studies, even we have done studies on electrogastrography and, gastroparesis, it improves once H. pylori gets eradicated. So it's been very clearly shown if there is a dysmotility of the stomach, the first thing that I would do is eradicate H. pylori. And then probably post eradication, if there is epigastric pain, burn, I would continue with PPIs because it has been beautifully shown even way back 30 years ago. I think Bardhan from UK and the Canadian group both in combination showed even after eradication of H. pylori, for the dyspepsia symptoms to go, it takes 6 months to 12 months. They took all these patients, every month they put in a Rayleigh tube, aspirated gastric acid, and also they were looking for H. pylori presence and all that continuously for 12 months. And they demonstrated so beautifully. It takes time for the remodeling of the stomach to happen. Even after eradication of H. pylori, still the acid levels will be high. It takes time to settle down. So I would follow up with, PPI after eradicating H. pylori, and then I'll call them back for reviews so that we can start stepping down the PPIs. If the patient also has a delayed gastric emptying or postprandial bloat or reflux, I would combine it with a prokinetic agent.
Thank you. I totally agree with you. I think that's a very nice way to put it. And I think it puts the whole thing in perspective. Yeah. So I think we've come to the last of our questions. So Dr. Gajanan, do you?
Sir, I would like to
Yes.
say a few words, sir.
Yes, absolutely.
So it's really amazing. So many people have asked questions. That means it has really kindled interest among the audience, this functional dyspepsia and acoshemite.